Morning, everyone. Welcome to the On-Air TV Primary Care Workshop. We are honored today to have our chairperson, Prof Dr. Safura Ramli, who is also a consultant family medicine specialist and deputy director of iPerform from UiTM. Prof. Anis, please.
Okay, thank you very much, Alvin. Assalamualaikum and a very good morning to everyone. It is with great pleasure that I welcome all of you to our primary care workshop today. Before we begin today, I have several housekeeping announcements to make. First of all delegates will be muted and on listen mode only for the entire webinar. Please do turn up the volume of your computer speaker so that you can have you are able to listen to the talks that we're going to deliver today. Questions can be submitted through the Q&A section provided in the platform. If you are locked out or not able to listen to the talk, please kindly re-log in, especially if you can't see the slides, then the issue will be resolved hopefully. You may also use the Q&A section and a moderator will assist you as soon as possible if you're facing any problem. Please minimize the speaker view for better viewing experience. Also, just a reminder on how to obtain your CPD points for doctors. 4 CPD points will be given for this webinar, which is 2 sessions. Please do download your MMA application form. CPD point QR code will be shared at the end of the session. As an alternative, attendance list will also be submitted. You can also submit it manually to MMA post-event for CPD points accreditation. So without further ado, now we are going to go through the session. So if we can have the moderator to, so we have that, yeah, okay. So first of all, our first talk today is going to be delivered by our esteemed speaker, Professor Dr. Chee Kok Han. It is my pleasure to introduce Prof. Chee this morning. Prof. Chee Kok Han is a senior consultant cardiologist practicing in University of Malaya Medical Center, and he also carries out his private practice in University of Malaya Specialist Center. Besides his clinical work, Prof. Chee also lectures in Medical Faculty. Prof. Chee has been granted full professor from in 2016. After the completion of his medical studies, Prof. Chee pursued his master's in internal medicine before pursuing his training and career in cardiology. Prof. Chee's interest in atrial fibrillation has led him to participate in many landmark trials like RELY, RELY-Asia, Relayable, Record F, AP, Averroes, and Athena. Prof. Chee is also involved recently in the EMPA-REG outcome trial. So with my great pleasure, I welcome Prof. Chee to deliver his talk.
Thank you, Prof. Dr. Anis. So it's my pleasure to be with you guys today in the primary care seminar. So I was given actually a very difficult topic and looking at whether the HbA1c is still the most paramount importance in diabetes care. Well, coming from a cardiologist, I think you expect me to say that HbA1c is actually not important in diabetes. I think the endocrinologists won't be very happy. I think most of them pull out like gun and say, no, HbA1c is definitely still relevant. So I'm going to talk about what is the relevance of HbA1c. To me, I think that HbA1c at this moment in time, I would say is definitely not the most paramount. All right, and I will actually go and talk about it over 3 important segments. It's actually looking at the observation studies, the therapeutic studies, and the cardiovascular outcome trials. So let's start with observation study. I think this is the slide that you all have seen many times, and I think this is a very important landmark study, the UK PDS study. And this is a slide that actually established the role of HbA1c in the diabetic care. In the bottom is looking across all the various HbA1c level, and as you can see here in the red color line are looking at myocardial infarct. As the HbA1c goes up, the rate of myocardial infarct also goes up. And looking at the microvascular endpoint, as you can see, is the same. As the HbA1c goes up, we are seeing more microvascular complication in this UK-PDS study. So this is actually the landmark trial of HbA1c, but UK-PDS is actually not the HbA1c trial. So if you actually look closely, the study design of the UK-PDS is actually a fasting plasma blood sugar trial. Patients are recruited based on fasting plasma glucose, and they actually randomized again based on fasting plasma glucose. And they are actually being randomized into conventional therapy, which their target is actually fasting less than 15. And for the intensive policy, the target fasting plasma sugar is less than 6. So this is the original design of UK-PDS. HbA1c is actually not the target. HbA1c is not the intervention target. In other words, you are not looking at the intensive arm trying to bring the HbA1c to a certain level. What the UK-PDS done is actually looking at fasting plasma glucose and bring it down to less than 6. And what we see of the HbA1c result is actually a post-hoc analysis. In fact, only about 60 to 65% of the study population UK-PDS actually have HbA1c level. In other words, the HbA1c was actually not a pre-specific endpoint. Maybe HbA1c at that moment in time back in 1990, when UK-PDS first started, HbA1c is actually not widely available yet. So this is the graph that you've seen. Now, nevertheless, in the intensive fasting blood sugar arm, they actually managed to bring down the HbA1c on average to 7. And the conventional fasting blood sugar arm, actually the HbA1c was around 7.9. The graph that you see essentially are HbA1c of all the patients, regardless whether they're on the intensive arm or whether they're on the conventional arm. So you do not see a graph like what you're supposed to see. On one arm is, let's see, on the HbA1c very intensive, on the other arm is HbA1c conventional. There's no such graph. So what you see as far as the outcome is concerned, essentially are looking at any diabetic related endpoint, then the intensive arm definitely are better. In other words, if you aim, just like what UK-PDS have done, looking at the fasting blood sugar, then if you bring the fasting blood sugar to less than 6, definitely they have much better diabetic related endpoint. But if you actually look at the endpoint individually, for example, the death, all-cause mortality, myocardial infarct, stroke, and also amputation or death for peripheral vascular disease, across all these macrovascular endpoints, most of it are actually not significant. All of them does cross the line of unity. That means the 95% confidence interval does cross a line. 1. In other words, aiming for a good fasting blood sugar less than 6 in UK-PDS does not change the outcome. What it changed essentially is at the end, the microvascular outcome is definitely significantly reduced with the intensive therapy. Again, please remember, intensive therapy here are not about HbA1c. It's about fasting blood sugar. So UK-PDS is a fasting blood sugar study. It's not a HbA1c study. So what can we conclude actually from UK-PDS? The higher HbA1c definitely will lead to more complication, and lower HbA1c will definitely is associated with less complication. So this is the conclusion from UK-PDS. This actually changed the guideline in the standard of care of American Diabetic Association in 2007. For example, they actually listed A1C target to be less than 7%, right? And if possible, you want to bring it down to as low as less than 6%. At that moment in time, we thought that normal A1C is less than 6. So in this 2007 guideline, they actually recommend to bring it down to even lower, less than 6 at the cost of increased risk of hypoglycemia. In other words, we are willing to let the patient suffer a little bit of hypoglycemia as long as the HbA1c is less than 6, because this has been shown in the UK PDS trial, as you have seen just now, to associate with actually less complication. And in fact, the whole algorithm back in 2007 is surrounded by A1C of more than 7 or less than 7, as you can see from here. So the decision making back in 2007 is all about what is the HbA1c. If it's more than 7, you up titrate the medicine. If it's less than 7, then you stop, right? But you try to aim for 7 or less. So this is based on the conclusion from the UK PDS trial that you have seen. But my question is, this is just an association. Can a therapeutic intervention to bring down the HbA1c, lowering down the HbA1c, actually reduce the complication or not? I agree. When you actually have higher HbA1c, you have more complication. But if you're going to give intervention, whether it's drugs, whether it's insulin or whatever, lowering down the HbA1c, will we actually reduce complication? So that is where we come to what I call the therapeutic studies. Because after the findings of UK PDS, we found that if the HbA1c is higher, you have more complication. If the HbA1c is lower, you have less complication. Let's do trial just to target patients' HbA1c as a treatment target. So as you can see here, in the UK PDS, the target is just looking at fasting blood sugar. So they actually have 3 important trials looking at type 2 diabetes, that is ACCORD, ADVANCE, and veteran VADT study. They are looking at HbA1c less than 6%, HbA1c less than 6.5%. In the veteran study, they're actually looking at absolute reduction of 1.5% in the HbA1c. So this 3 trial is different from the UK PDS. UK PDS are using fasting blood sugar as the intervention, but ACCORD, ADVANCE, and VADT are using HbA1c as treatment target. This is quite close to what you and I is practicing. That means we see a patient, we want to target the HbA1c, say 6 or 6.5, or looking at absolute reduction of 1.5. For example, if the patient baseline is 8, then we want to bring it down to say 6.5, for example. And in the trial, they managed to do it, right? In a ACCORD trial, they bring it down to 6.4. In ADVANCE trial, they bring it down to 6.5. In VADT, they bring it down to 6.9. So what we expect from the intensive arm or all these 3 trials is that we should see a better cardiovascular outcome. We should see better microvascular outcome based on what we learned from the UK PDS study. But that is not true. As you can see here, I just summarized for you. If you actually look at the cardiovascular outcome across all the intensive arm, they are the same. In other words, bringing down the HbA1c to 6.4 or 6.5 did not reduce the cardiovascular outcome. In fact, in one of the study, which is a ACCORD study, the lower HbA1c in the intensive arm actually increased mortality in the ACCORD trial. So this is the original publication of ACCORD trial. As you can see here, the intensive therapy actually have more death compared with standard therapy. Intensive therapy is the one that we aim HbA1c around 6.4. In the standard therapy is around 7 point something. And yet intensive arm actually have more death with a p-value of significant. So you may say that the ACCORD trial, maybe we should run it a bit longer to see the legacy effect of the intensive diabetic treatment. So they actually have published a 14 years follow-up from the ACCORD study. And yet at the end of around 14 years, you do not see any changes. The graph still look diverge as the same, where the top line is the intensive arm and the bottom line is the conventional arm. They still have more cardiovascular death in the intensive arm compared in the conventional arm with a p-value of 0.02. In other words, intensive therapy does not reduce cardiovascular death, whether it's first 5 years or subsequent 10 years or so. This again is seen in the other trial called Advance. When they follow up to around 10 years, you're still seeing the same. There's actually no significant difference as far as major adverse cardiovascular event is concerned. So based on these two trials, what we learned is that intensive therapy aiming at HbA1c around 6 does not actually change outcome. In fact, you also can see the standard of care or the American Diabetic Guideline also have changed from 2007 to about 2015. Instead of saying that you should achieve a good HbA1c as normal as possible, which is around 6, now they're talking about individualized A1C target. Instead of what you have seen just now, where the whole algorithm is about A1C target, now they're looking at every patient has a different kind of target HbA1c. For example, how long have they have the illness? What is their life expectancy? Do they have established vascular complication? So all this will actually decide what is the HbA1c for each individual instead of what you see in the original in 2007, where HbA1c is the target of the diabetic intervention. So HbA1c as a therapeutic target, all right, as a therapeutic target, does not actually reduce MACE. When I say does not reduce MACE, when you bring it down to around 6 or 6.5, but it has been shown it does reduce the neuropathy and microvascular complication. This is mainly based on UK BDS trial and subsequently the one study and court study. So until 2015, this is the guideline, all right? So you can choose any medication, whether it's sulfonylurea, DPP-4 and all that. And the decision to tell which oral hypoglycemic agent is used is all depend on what is the efficacy, what is the risk of getting hypoglycemia, are you looking to actually to reduce the body weight, what are the side effects, and of course the cost of the medication. So these are the various consideration when you actually decide what medication to use. But as coming back to HbA1c, they still stick to the individualized HbA1c. That is back in 2015. And in 2015, the whole scenario changed again because of cardiovascular outcome trial. These are the two first cardiovascular outcome trials that actually again change how you and I look at HbA1c again. First is the EMPIREC study using empagliflozin, one of the SGLT2 inhibitors. Then the other one is LEADER trial looking at liraglutide, one of the GLP-1 receptor agonists. So the first one is EMPIREC study. For the first time, you see that in a diabetic trial, you are seeing a reduction of major adverse cardiovascular event or MACE, inclusive of cardiac death, non-fatal stroke, and MI. So as you can see here, the empagliflozin group actually achieved significant reduction of all the MACE compared with the conventional study, and they actually reduced all the 3-point MACE very, very early in time within the first couple of months of the study. And if you actually look at the HbA1c that achieved, frankly speaking, is actually not very, very significant. It dropped about 0.5% in the empagliflozin arm in the first couple of weeks. But at the end of the study, I think the difference is only about 0.4 to 0.5%. So it's actually not a lot of HbA1c reduction. The other trial using GLP-1 receptor agonist, liraglutide, again show a superiority of liraglutide versus standard therapy among patients. And again, if you actually look at the HbA1c achievement, it does achieve around very, very good achievement, as much as about 1% drop in the first couple of weeks. And then after that, at the end of the study, I think the difference again is about 0.4 to 0.6% between the liraglutide arm versus the standard therapy arm. So to put in all in a nutshell, in this summary table, you can see that EMPIREC and LEADER, as far as HbA1c achievement is concerned, is definitely not as good as what you see in the ones of VADT, and yet you actually see much better outcome. So just to put it side by side, On your left-hand side is actually advanced and VADT. You do not see any separation of graph in the cardiovascular outcome, standard versus intensive. Here are using HbA1c as your treatment target, aim around 6 to 6.5. On the other hand, EMPA-REG and LEADER actually showed not looking specifically at HbA1c, you just give them the correct medicine, you just give them the right medication, you can achieve a good cardiac outcome in these two studies. And this is not the one-off result, all right? Or you can see that the EMPA-REG does reduce cardiovascular and also reduce all-cause mortality, while UKPDS and ACCORD did not show the thing. It did not show the similar benefit. And this is not just one-off result. SGLT2, for example, has subsequently declared CANVAS and VERTIS, so similar beneficial result. And other GLP-1 receptor agonists from LEADER, REWIND, SUSTAIN, PIONEER, and HARMONY also show a similar benefit as far as cardiovascular outcome is concerned. And my next speaker will speak more on these two substances that actually also improve the kidney outcome. So I think the ADA guidelines definitely have changed to this selection of medication based on the drug efficacy, hypoglycemic risk, and weight impact on the weight. Now they actually have changed it. I'm showing you the latest standard of care of American Diabetic Guideline 2021. I will start from the top. First line therapy is still metformin and comprehensive lifestyle modification. And then the next thing is actually look at the high risk or established cardiovascular disease, chronic kidney disease, or heart failure. But the most important point about HbA1c come next. I think please read together with me. Consider independently of baseline A1C. So you should consider the medication independently of what the patient's baseline A1C. You also consider independently whatever your patient's individualized A1C target, or whether the patient is on metformin or not. In other words, please start all this medication, whatever the HbA1c is. Please start all this medication, whatever the HbA1c is. So that tells you that A1c have actually no role at all in making decision. It's actually whether they have established cardiovascular disease, chronic kidney disease, or heart failure. If the patient have all these high-risk disease, then they should be given what we have mentioned just now, the SGLT2 inhibitor, GLP-1 receptor agonist. In heart failure, SGLT2 inhibitors. In chronic kidney disease, SGLT2 inhibitor, preferably followed by GLP-1 receptor agonist. So I think the ADA 2021 actually have definitely say A1C actually have no major role for you to decide what medication to be on, right? It's whether the patients have high risk or established complication from the diabetic or not. So this is about a high risk group. On the other one that doesn't have any of the high risk disease such as cardiovascular disease, kidney or heart failure, then they come to this side, and this will come back to the individualized HbA1c target. That will be, then the choices is all whether you want to minimize the hypoglycemia, you want to reduce the body weight, or cost is a major issue. So in conclusion from the ADA guideline, I think high-risk diabetic patients, especially the established cardiovascular disease, heart failure, especially the heart failure with reduced ejection fraction, chronic kidney disease, should be given SGLT2 inhibitor and GLP-1 receptor agonist based on all the cardiovascular outcome trial. And this should be given regardless of HbA1c at baseline or whatever the target is. In other words, HbA1c have no say what medication should be used. You should give it to this group of patients regardless their HbA1c result. So my take about HbA1c definitely is not the most paramount in diabetic care, but maybe it's still very, very important in diabetic care. I think these are the three areas that HbA1c is still definitely important: the diagnosis, the prognosis, and the monitoring of diabetic patient in our diabetic clinic. Definitely the diagnosis nowadays incorporate HbA1c is one of the diagnoses. If the HbA1c is 6.2, 5.6 to 6.2, they are considered pre-diabetes. And if their HbA1c is more than 6.3, then they're considered as diabetes. This guideline most likely will be changed today, later, once they actually announce a new guideline. Definitely the HbA1c will give us some prognosis information. This is based on UK-PDS trial that you have seen just now. The higher the HbA1c is, then you know the patient will definitely have much higher risk of getting MI and microvascular complication. It's definitely a good way to monitor the patient's diabetic status. Number one, it's actually widely available. It's still relatively cheap, and it's actually very easy to understand, right? So this is something that I think is still give us variable information. Definitely will be very helpful in our day-to-day practice, right? You know, there are some patients who can cheat in their fasting blood sugar by not eating for 24 hours, then they will give you a very nice fasting blood sugar. But the HbA1c will be able to tell you over the past 2 to 3 months, how is the diabetic control. So I think this HbA1c definitely is very important in how you and I manage a diabetic patient. But if you actually look at it as a treatment target, I think now they actually advocate individualized HbA1c based on whether the patient is young or old, whether it's a new diabetic or has been having diabetic for a long, long time. It's very, very nice to have this very individualized HbA1c, but you and I sitting at the front line, it's like, how am I going to decide, right? What is the right HbA1c for the patient that is actually sitting in front of me? So if you actually look at the guideline to make things easier, the ADA guideline in 2021 actually says that 7% will be the rough idea for most of the patients. This is a good target to aim. So personally, I will use about 6.5 to about 7.5 in most of my patients, and the level evidence is actually A. That means there's a lot of good evidence about it. But if you want to go lower, anything less than 7, make sure that you can achieve it without significant hypoglycemia or side effect from the medication. You can try to do it. However, the level of evidence is actually not as good as what you have seen just now with the level of evidence of C. So in other words, most of the patients in your practice and my practice, most likely 7% plus minus 0.2 to 0.3, that will be the rough target for this group of patients. But if you actually look back, what is actually HbA1c? Essentially, are looking at glucose glycolated red blood cells. So it's actually looking at the average of glucose level for the past 2 to 3 months or 6 to 8 weeks. So it's actually just an average. Why? Average does not mean anything. As you can see here, average does not reflect the glycemic excursion. These two patients also have HbA1c of 8%, but as you can see here, patient A definitely have much more different high and low in their sugar, while second patient actually have much narrow sugar level. So you know that patient A will definitely are not going to do as well as patient B. Patient A will definitely have more complication compared with patient B. So this is a problem with HbA1c. HbA1c does not reflect this. So I think we are going towards continuous glucose monitoring. That means the patient's glucose can be monitored nearly every minute. So I think this is where it's going. The technology is actually available in Malaysia. It's actually not painful. You just put a patch onto the skin and it actually can sync to your handphone or a device to look at minute to minute or hour to hour sugar level. I think this is something very good. And this can give you a picture like this, where you can show whether the patient's sugar is in range or not in range. I think this is a future. Instead of looking at HbA1c, which is actually the average over the past 4 to 6 weeks, now you actually can do continuous glucose monitoring non-invasively, looking at day-to-day sugar changes. In fact, just a couple of days ago, they have rumors saying that Apple Watch Series 7 may going to give you blood sugar monitoring. So I think in future, this will be the future of how you and I manage. I know the cost is very high now. Technology is not here, maybe it's somewhere around us already, but I think this is the way to go in future. So my conclusion for today's topic is HbA1c definitely is not the most paramount in diabetic care. It's somewhat important, right? But for now, until the continuous blood sugar monitoring become very, very simple, very, very cheap for us to use. So I know the endocrinologists will not be happy with me, but I would like to have questions from all of you later. So thank you very much. Back to you, Prof. Anis.
Thank you very much, Prof. Chee, for the very enlightening talk. I am sure our participants have got lots of burning questions for Prof. Chee. So please do submit the questions through our Q&A box. Thank you very much, Prof. Chee. We'll see you later during the panel expert discussion and the Q&A session. So it is with great pleasure, I would now introduce first the next speaker who's going to talk about diabetes at the forefront of kidney disease. So we have Associate Professor Dr. Ruslinda Mustafar, who is a consultant physician nephrologist and currently the head of nephrology unit at the University Kebangsaan Malaysia Medical Center. Associate Prof. Ruslinda graduated from the National University of Malaysia. She then completed her nephrology specialist training in UKM and did her renal transplant attachment at the Guy's and St. Thomas Hospital in the UK. Associate Prof. Ruslinda has participated as investigator in several multi-center studies. Her areas of research interest include chronic kidney disease, hemodialysis, primary glomerulonephritis, and extracorporeal therapy. She is currently a lecturer at the Department of Internal Medicine at UMMC. So with great pleasure, we welcome Prof. Ruslinda to deliver her talk.
All right, Assalamualaikum, good morning everyone. It's a pleasure to be here. Thank you, Prof. Anis, for your kind introductions. Well, I believe we have received a very interesting talk from the Prof. Chee. And of course, what I'm going to do today is basically definitely focus on CKD and diabetes. And I'm not going to spend so much time to elaborate on the clinical trial, the existing one and the current one, but of course, I will summarize them. The most important as what I believe is to understand how we can incorporate the existing data into our day-to-day clinical practice. Yeah. So I have nothing to disclose. So these are my contents of my lecture, the contents of my lecture. We're going to start with the definition of CKD. And we need to understand as nephrologists why I feel so bad about managing CKD, right? All right. I'm sure you all aware how to define CKD. Basically, chronic kidney disease is defined as abnormalities of kidney structure or functions that present for more than 3 months. And of course, this does have a lot of clinical implications. And diabetic kidney disease, sometimes you may heard, some people say diabetic kidney disease, some people may say diabetic nephropathy. This can be interchangeable. Yeah, diabetic kidney disease is basically is a clinical diagnosis. You measure the eGFR, you have albuminuria, along with clinical characteristic of diabetes, the duration of diabetes, and other target complications such as retinopathy, which is very specific determinant of the diabetic nephropathy. Whereas diabetic nephropathy basically is clear-cut, well-identifiable kidney disease proven. What I meant by proven, normally from a kidney biopsy. So we do have some patients that we biopsy the kidney, and the patient also has diabetes. So when we saw the changes in the kidney due to diabetes, we term it diabetic nephropathy. Whereas DKD, when you're dealing with patient, we never biopsy but the patient have reduced eGFR, has proteinuria, and have a very clear-cut long durations of diabetes, we term it diabetes kidney disease. Okay, it's very clear. All right, so how do we measure kidney functions? So the way that we measure kidney function basically use our estimated glomerular filtration rate, and albuminuria. This is very simple. So basically, glomerular filtration rate declines to the levels below the reference only when you have extensive kidney damage. So the earlier part, actually, we do have some changes, but it wasn't detected. All right. So the most important, the earliest sign of kidney disease in diabetes, basically albuminuria, where there is an increase in glomerular permeability, and it's a direct measure of kidney damage before the loss in function. So how to measure albuminuria? Of course, it depends on where you practice, up to you. You may use urine albumin creatinine ratio, you may use urine PCI, or urine protein. And of course, try to make things more simplified. Rather than in the past, we always go by 24 hours urine protein or urine albumin. Nowadays, we only go for spot urine test, which is more simple and available in any KK or primary care out there. Very simple. So it's very important for us to understand how do we define CKD. This is a very nice view of two-dimensional assessment of CKD. As you can see on your right-hand side, based on GFR categories, on the y-axis, basically based on the albuminuria stages. Very important. When we talk about CKD, please look at these two components. I just need these two components, all right? So you measure their creatinine. After that, you calculate their eGFR based on existing calculator. You can use CKD-AP, some people use MDRD, whatever. But you have to measure the eGFR. Some blood tests also, they automatically measure for you. That's going to be very easy. So stage them into 1, 2, 3A, 3B, 4, and 5. You must understand the lower the eGFR, the more likely the patient going to progress to end stage, then they are very high risk on the red area. Now we move on into the Y side. Y-axis, as you can see here, we have A1, A2, A3. Basically, if the UACR less than 30 is considered normal or just mildly increased, even though they are group 1 or 2, they are not considered high risk of CKD. They are very high risk of progression. They are low risk. But bear in mind, the more the protein albuminuria, the more likelihood that this patient will progress into advanced kidney disease and kidney failure. So basically for nephrologists, the earlier marker is albuminuria. So if the patient has albuminuria, I want you to tackle this problem earlier, not later, not when the patient already have nephrotic syndrome. When the patient presented to my clinic, it's going to be very tough for us to manage the patient. All right, so who are at risk of CKD? Of course, we are all now feeling the heat of a COVID pandemic, right? So yesterday, the case almost reaching 6,000. All of us are very scared about COVID-19, but we have to bear in mind that we also need to manage our other diseases very well, especially diabetic. And as nephrologists, to me, diabetes mellitus is another long-lasting pandemic. The only difference is they are not contagious, all right? They are long-lasting pandemic. So as you can see, the top point, who are at risk of CKD, diabetes mellitus, followed by hypertension. And of course, as you can see here, if you are more than 65-year-old, you have obesity, you have a cardiovascular disease, metabolic syndrome, you are not certain drug that potentially nephrotoxic to the kidneys. If you have family history of CKD, CAD, other autoimmune disease, these are the patients that may progress to end-stage renal failure. And you must understand, as nephrologists, what I would like to know that these patients, as mentioned here, should not end up with dialysis, and they should not die of end-stage renal failure or complications of end-stage or diabetes. Very simple. Don't let them progress into advanced CKD and kidney failure, because after that, a lot of complications can happen. All right, this figure just to show to you that over the years, diabetes is the leading cause for new dialysis patients in Malaysia. At the moment, we have around 60,000 patients on dialysis. I'm talking on dialysis, and 70% of these patients, even new dialysis patients, due to diabetes. So if you were to ask us nephrologists, who is our main enemy, definitely those, diabetes mellitus. Yeah? We are so scared when dealing patients with diabetes mellitus. They will end up and progress into kidney failure. And to make things worse, yeah, based on the recent National Health Mobility Survey in 2019, this figure is going to be very scary. 1 in 5 of adults in Malaysia have diabetes. And to be honest with you, if you look at the data on the planet, I'm talking on the planet, 1 in 12 having diabetes. This is a scary figure. We need to reduce this number. And that's about 1 in 5, that's about 3.9 million Malaysians have diabetes. So just imagine if we did not halt this problem or stop this issue, so eventually this patient will end up with kidney failure or heart failure or CV complication and die because of that. All right, as I mentioned early on, the number is scary, 11.2%, 13.4% until lately 18.3% Malaysians have diabetes. And because of that as well, I need to emphasize also that the numbers of CKD, I'm not talking about on dialysis, CKD in Malaysia has doubled from 9% to 15% prevalence. So 1 in 5, from 1 in 9 now become 1 in 5 Malaysians also have CKD. Why we feel so bad about diabetes, basically this timeline well characterized for type 1 diabetes, but nonetheless, let me tell you something, that we hate hyperglycemia. When the patient have hyperglycemia, there is a lot of alterations happen to the nephrons, to the kidneys. Initially, the first 5 years, what you could see, eGFR will go higher. So it goes undetected, because if you are so obsessed about creatinine, actually whatever changes in the kidney undetected based on the serum creatinine and eGFR. What happened to the patient? Just a period of hyperfiltrations. But nonetheless, in the kidney itself, you're going to see a lot of changes in terms of cellular injury, mesangial expansion, sclerosis eventually, and so on and so forth. And what will happen subsequently after 5-10 years, the patient started to have microalbuminuria at the early stage. This is where I want all of us need to tackle the issue early, before they become macro, before they become overt proteinuria, and eventually they have reduced eGFR and become end-stage kidney failure. And after that, they're going to have many more complications, including death. So this is should not happen. We should not allow this patient to pass through this stage. All right, again and again, we're going to say that presence of CKD associated with development of fatal CV event. Those patients more than 65-year-old, 6 times likely to die of CV disease before they end up into dialysis. But if we talk about those eventually end up with dialysis, 50% of them die of CV complication. So it's like a circle, you cannot talk CKD on its own and stage 1 without talking about CV complications, right? So now you understand the burden, you know how to diagnose CKD. So how to screen? Very simple. I repeat again, just do a blood test, renal function test, measure the eGFR, calculate the, measure the creatinine, calculate the eGFR, has some dipstick, or urinalysis, and of course you can quantify based on urine albumin creatinine ratio. You may consider ultrasound if necessary. It's not mandatory, if it is necessary only. So ADA consensus recommend at least once a year in diabetic patient to assess the albuminuria and also eGFR in type 1 after 5 years of diagnosis, in type 2 at the diagnosis. If the patient had albuminuria or eGFR less than 60, you should monitor them at least 6 monthly, or it can be more frequent, no problem with that, all right? So what about our Malaysian CKD CPJ in 2018 for diabetes mellitus? Similarly, we have to monitor them early based on simple tests, just a urine dipstick for protein. For type 1 diabetes, after 5 years, for type 2 at the time of diagnosis, because we believe the patient already had the diabetes much earlier. If negative, of course, you can screen for albuminuria, early morning spot. If positive, of course, don't take the result as indirectly. You have to remeasure, because there are so many other things that can give rise to false positive albuminuria, such as UTI, even those patients with heart failure. Retest. If consistently positive, then truly that this patient has albuminuria, then you have to tackle them from there onwards. If none, then yearly. If the patient from the dipstick already had proteinuria, so of course this patient already had overt nephropathy, and of course you have to monitor the patient accordingly. So now we understand how to screen them, right? So how to manage the patient with diabetes, diabetic kidney disease. Importantly, we are talking as what Prof Chee mentions about A1C, A1C, A1C. But of course, I would like to emphasize again, don't allow the A1C become uncontrolled. Yeah. So basically, as nephrologists, generally I'll take 7%, but I do agree with Prof Chee, we have to have a personalized medicines. Yeah. Individualization is very important. After that, the next most important point is basically to make sure their blood pressure into target, less than 130/80. Try to achieve this with an appropriate antihypertensive. Of course, if diabetic patient, we always advocate to use ACE inhibitor or ARB as part of the antihypertensive medication, right? And of course, consider other risk factors management for atherosclerotic event. You may consider SGLT2 inhibitors if the patient has adequate eGFR. But again, ACE and ARB is very important in the management of diabetic kidney disease. All right, this is based on the old research, old clinical trial. So again, target A1C, Dr. Chee have alluded nicely, personalized. You can have a range between 6.5 to 8, but we have to select our patient carefully. Most advanced CKD patients, I tend to allow them up to 8% because they're also elderly. They're around 70, sometimes 80 years old, and they have frequent hypoglycemia. So I don't go like emphasize so much so on bringing the A1C down to 7 or 6.5%. Sometimes we must understand this patient can tell you, doctor, when my fasting sugar 6 millimole are already shaky, I feel fainted, I got a fainting spell. It's very important to listen to the patient. Similarly, KDIGO says the same, around 7, but in those patients who has multiple comorbid, relax a little bit, allow them up to 8%. All right. Okay, now when we talk about A1C, again, I emphasize carefully look at their eGFR, all right? If their eGFR not fall into the severe or moderate risk, try to aim around 7%. Of course, you have to look at other parameters as well. The choice of anti-diabetic agent should be something that can renal protective, especially is ARB, especially those medications who have renal protectives, what I meant is SGLT2 or GLP. All right, so now I talk a lot about diabetes. What I would like to emphasize based on this very nice study from the Creek cohort. So basically, if we have the patient at stage 3A, the longer the patient spend at that stage, around 7.5 years, the lower the KD stage, the lesser the patient spend on that CKD stage. But bear in mind, if the patient also have a poorly diabetes and the systolic BP not into target more than 140 millimeter mercury, so more years lost in that particular stage. So it's very important in managing diabetes CKD. You are not only looking at the CKD alone, you are not supposed to look at the diabetes alone, but we have to look at the patients as a whole, holistic. So again here, when we talk about treating to goal, what I would like to emphasize, try to achieve all risk factors into target. If we manage to achieve all risk factors into target, we can reduce the risk almost 60% risk reduction from developing kidney failure. All right. And interestingly, when we talk about CKD progression in diabetes, the process very complex actually, but again, there is a lot of happening in the kidney, the nephron in particular, hemodynamic changes, metabolic changes, and of course, eventually this will lead to inflammation and fibrosis. Again, what happened to the nephrons, the functioning unit of the kidney, a lot of changes, ultrastructure changes eventually cause increased vascular permeability because it altered our glomerular basement membrane, stellar expansion, hypertrophy, sclerosis like scarring, and later on the patient become lost the nephron and then developed CKD. All right, since 2015, as a nephrologist, I was fascinated with the clinical trial on diabetics medications for the CV safety. All right, we started with empagliflozin in 2016. After that, we have canagliflozin and dapagliflozin, and of course, recently we have etripgliflozin. And this study is basically a CV outcome trial, but they also assess on the kidneys outcome, right? Very interesting studies for the last 5 years. We also have glucagon-like peptide 1 receptor agonist. It is a CV outcome trial, but also try to look at the kidney outcome. So when we talk about kidneys, when we talk about cardiovascular, we also, nonetheless, we have to talk about kidneys. We are a big friends each other. So we have semaglutide, liraglutide, and so on and so forth. For me as nephrologist, it's so difficult to pronounce these drugs. What I want to summarize to you that comparing SGLT2 inhibitor and GLP-1 receptor agonist, basically SGLT2 inhibitor have a consistent benefit, renal benefit, heart kidney endpoint as defined as a kidney failure, doubling on serum creatinine and kidney death, albuminuria, and eGFR decline if you were to use SGLT2 inhibitor. But if you were to use GLP-1 receptor agonist, in terms of heart kidney endpoint, the evidence is not that clear. eGFR decline is not that clear, but it's good for albuminuria. All right. So we have to decide where we should and how which medication that we should prescribe to our patient. All right. In terms of A1C, Prof Chee have mentioned that A1C reduction for this group of drug SGLT2 inhibitor, basically around 0.4 to 0.7%, but you must realize that the more lower the eGFR, the less benefit to the A1C reduction. However, in terms of body weight and blood pressure reduction has been consistently irregardless the kidney functions. That's very good. So basically, I would say that the effects of GLT2 on the renal outcome is independent of A1C. Independent of A1C. All right, so this slide basically summarizes everything. As you can see here, whatever studies, I'm sure we have many more studies coming. Actually, we have a DAPA CKD as well that shown to us that the result of this SGLT2 on the kidneys definitely very interesting. And as a nephrologist, I think now potentially we as nephrologists has a wondrous drugs on the market already in the form of SGLT2. And of course, it's consistent, okay, it favors SGLT2 in terms of kidney-related outcome. All right. As you can see in this slide as well, okay, we look at the hard endpoint or soft endpoint, whatever it is, the result has been very good in favor of SGLT2. In this study, basically, we use empagliflozin. Very good, whichever way you're trying to look, it favors SGLT2 inhibitor. In this slide, basically, empagliflozin. Beautiful. For me as nephrologist, I have something out there that should be prescribed in diabetes patient with CKD, provided the eGFR allowed you to prescribe these drugs. All right, again, similarly, if you put, this is EMPA outcome trial. So compare empagliflozin and placebo, 39% risk reductions to incident or worsening nephropathy. And here in this slide, okay, this is a lot of concerns among primary care and even among nephrologists. Once we started on empagliflozin, right, you see some dip in the eGFR. But to be honest with you, this dip in eGFR is because of the alterations, hemodynamic alteration in the transglomerular feedback mechanism, all right? And whatever it is afterwards, there is a sustained decline of the eGFR in placebo group compared to EMPA group, where the eGFR pretty much very stable. So don't worry, over these 3.7 years of follow-up, even though you see initial dip, after that the kidney function pretty much stable. So if we are concerned about this dip, whether it's going to be persistent, as shown in this slide, basically, if we stop the MPA or the SGLT2, basically the EGFR increase back to the baseline. So it's something reversible, People sometimes did ask me, should I monitor the serum creatinine after initiation? My answer, it depends on your patient's profile. Yeah? If the patient is very frail, elderly, you might think there are so many others that might contribute and you're worried also, you can monitor. If you're starting in those patients very healthy, young, fit, you don't have to monitor the serum creatinine at 2 weeks or 1 month of initiation. All right, I'm sorry, okay. If we was to stratify this drug based on the EGFR at the baseline, as you can see here, regardless of EGFR, the drug has done wonders. All right, the EGFR is stable, even though at baseline they are less than 60 mL per minute or even more than 60 mL per minute. Similarly, if you stratify them in terms of albuminuria, of course, as I mentioned earlier, those who have macroalbuminuria, more than 30 milligram per gram, benefit the most with SGLT2 inhibitors as compared to normal albuminuria. And is this slide again just to show to you, to emphasize to you again and again that renal kidney outcome has been consistently good in patients irregardless their EGFR, irregardless their albuminuria level. All right, so if you look at the East Asia data, this study was carried out in Japan, Korea, and Taiwan. The effectiveness of MPA in preventing hospitalization of heart failure, risk reduction about 18% here, all-cause mortality about 36% here, and of course, risk reduction for end-stage renal failure is about 63%. 63%. 30 is around. Yeah. So basically, this result has been consistent across the countries. So this is a really good drugs, wonders drugs. All right. All right. So now we talk a lot on kidney protection, how it works basically. What I would like to emphasize to you, there are many hypothetical mechanisms. It reduces the blood pressure, it causes weight loss, improve glycemia, of course, and of course, in studies, it also has been improve oxygenation, reduce inflammation, but as I mentioned to you, it reduced hyperfiltrations, and of course, eventually reduce glomerular pressure. So let me show to you, this is a normal healthy kidney. So we have our afferent arteriole, efferent arteriole, and this is our glomerulus. So this is proximal tubule, and our SGLT2 transporter sits at the proximal tubule. In normal healthy kidney, when the sodium and glucose being filtered out, so basically some will be reabsorbed and some will pass through to macula densa normal. So nothing will happen, all right? So what happened in the diabetes patient, you must understand that in diabetic patient, we have increased expressions of SGLT2 in the proximal tubule. So what happened in diabetic patient, they have hyperglycemia, therefore they have glycosuria. So when the glucose being filtered out together with sodium, there will be a lot of reabsorptions of glucose and sodium because of this increased expression of sodium and glucose co-transporter. So what happened? There will be less sodium passed through to the macula densa. So macula densa will sense this, and of course the process very complex. Eventually what happened, there will be a dilatations of afferent arterioles in the kidney. When there is a dilatations of afferent, there will be more blood filtered through the kidney. That's where the stages of hyperfiltrations happen in diabetes patient at the early stage of CKD. So what happened? When there is more blood filtered out, so basically increase in glomerular pressure, so eventually increase in EGFR at the first stage. So increase in glomerular pressure to nephrologists, to me, is basically eventually as a long term will lead to nephron loss because the nephrons works harder as usual compared to usual. So what happened? The patient going to have a albuminuria eventually. So when we started the patient on MPA or other SGLT2 inhibitor, what happened? We tried to modify this All right, this is what happened in diabetes patient. We block the SGLT2, and then when the glucose filtered out through the kidneys, all right, so less reabsorption, so there will be a restoration of sodium passing through the distal tubule to macula densa. So basically macula densa will sense that, and it return back your afferent arteriole to its normal structure. So vasoconstriction happened. So what happened? Yeah, less blood filtered out in that particular nephron. So this eventually will reduce the glomerular pressure and then reduce in GFR. That's why initially, once you initiated the SGLT inhibitor, we definitely going to see some dip in the eGFR, but that's okay. All right. So based on this understanding, so what are the existing guidelines says how to manage DKD? So this has been alluded very well. ADA, ERA, EESD, and even European Society of Cardiology do recommend that, patients with type 2 diabetes and CKD, SGLT2 inhibitors have been shown consistently to reduce risk of CKD progressions, and this drug is recommended. If the patient cannot tolerate SGLT2 inhibitor or eGFR is not adequate, or too advanced, you may consider GLP-1 if the with proven CV benefits. All right, and all right, KDIGO similarly recommended the same thing. The most important, the fundamental lifestyle, physical activity, nutrition, and weight loss. If the patient eGFR more than 30, you may consider metformin as first line and discontinue metformin if less than 30, and you can initiate SGLT2 inhibitor. But you must remember that SGLT2 inhibitor do not initiate if the eGFR less than 30. It's so far contraindicated. We have to wait from the EMPA kidney studies in 2022 next year. After that, you can choose whatever anti-diabetic medications as long as try to prevent hypoglycemia. You have to individualize imaging this patient. Again, KDIGO recommended if we already meet glycemic target, if you target 8%, can lower glycemic target be safely achieved with SGLT2 inhibitor? If no, if you think the SGLT2 inhibitor is very important for CV or renal protection, then you may consider adjunctive of the existing anti-diabetic medication. If not achieved, simple, you just add on SGLT2 inhibitor and monitor the patient. All right, again, KDIGO 2020 recommend that the most important, all patients with diabetic kidney disease, you must advise them smoking cessation, regular exercise, 150 minutes per week, good nutrition, good lipids management, good glycemic control. Again, I emphasize individualized, of course, control the blood pressure in all patients. And most patients should be put on RAS blockade and SGLT2. Of course, in some patients with severe risk, you put them on antiplatelet therapy. And again, as nephrologists, SGLT2 available in nature at the moment, not allowed to be prescribed when the eGFR less than 30. So now, basically, as nephrologist in my clinic, I do see most of my patients, 70%, their eGFR already less than 30. So I want you out there who's managing the earlier stages of CKD to manage them early with these wondrous drugs. Right, so now I summarize my earlier conversations. So basically, kidney disease in patients with type 2 diabetes definitely associated with reduced life expectancy and very high CV mortality. Systemic effect of hyperglycemia in patients with type 2 diabetes ultimately will lead to nephron loss. It will cause albuminuria, and if we do not do something, we are not doing anything to the patient will progress to advanced kidney failure. And of course, the approach in managing patients with diabetic kidney disease multifactorial. We cannot just talk about diabetes A1C alone. We have to treat the patient holistically. Consider SGLT2 inhibitor when you see patient with diabetes mellitus, as well as you may consider GLP-1 receptor agonist accordingly. And whatever you try to prescribe, you must have evidence based on what you are doing. All right, with that, I thank you.
Thank you very much, Associate Prof Ruslinda, for the highly enlightening talk there on CKD. Again, questions from the participants are welcome. You can post it in the Q&A box and then we'll address them later. So it is indeed that we are champions in terms of diabetes prevalence as well as CKD prevalence as well, I'm sure. Now we have come to the highlight of the session. We have Professor Dr. Rohana Abdul Ghani, who's going to talk about what's new in the diabetes-related guidelines. But before that, let me introduce her. Prof. Rohana is currently a consultant endocrinologist and deputy dean in postgraduate and professional training at the Faculty of Medicine, University Technology Mara, UiTM. She is involved in teaching of both undergraduate and postgraduate programs, as well as providing endocrine services and running the weight management clinic at the UiTM Medical Center. Prof. Rohana is actively involved in research, particularly in the areas of diabetes and obesity. She has supervised master's and PhD students in the areas of gestational diabetes mellitus, and she is currently a committee member of the Clinical Practice Guideline for Gestational Diabetes 2017, and also the current guideline that she's going to be talking about. Welcome, Prof. Rohana.
Assalamualaikum and a very good morning. Thank you very much, Prof. Anis, for that very kind introduction. Thank you for the organizing committee for the invitation for me to be here today. It is indeed a privilege for me to share the platform with two esteemed speakers. I would like to have a debate with Prof. Chee at some point regarding that topic that he just presented. However, he is mostly very serious, so he kind of scares me as well. But anyway, it was a very interesting topic. So I do hope that I will be able to share probably a different perspective in terms of how endocrinologists look at the management of diabetes. So however, that I digress. So what is the topic given to me is really what's new in diabetes and what are the related guidelines. My two colleagues have presented some of the guidelines, so I hope that I can just breeze through them. I'm very conscious of the time. So these are my disclosures. I do receive honorarium for the talks such as this. Allow me to start with this. I'm sure this is a typical case that you see in your practice, 58-year-old, long-standing diabetes with the two comorbidities, hypertension and hyperlipidemia. And as well as that he had acute myocardial infarction in 2015, slightly reduced ejection fraction, however, currently quite comfortable. And these are the list of medications that most of our patients are on. I'm sure you're very much aware of that. And on top of that, he's got evidence of early CKD with eGFR of right around of 45 with HbA1c of 8.5%. Okay, HbA1c is 8.5%. Right, so how would you manage this patient? And I'm sure you'll be looking forward to the CPG that we're launching today, later today. So however, having gone through the two talks previously, Prof. Chee has something against HbA1c, but putting it into perspective that HbA1c is still the number one thing that you look at in the management of type 2 diabetes, because that will kind of give you a direction on where you're heading in terms of the management. So whether you want to go higher or you want to relax a little bit, as Linda was alluding to earlier. So in terms of the multifactorial approach, however, HbA1c, 7% I've put here, it is to be individualized based on patients' comorbidities. And that would include blood pressure lowering. So you must also take note of the blood pressure target of 130/80 at those with higher risk, and probably a bit higher in those with lower risk for CV disease. And obviously, you know about statins and the new PCSK9 inhibitors, and that is to target LDL lowering of less than 1.8 and 2.6 with those at moderate risk. But most importantly, that we fail to address, I think, enough is the weight loss and smoking cessation. There was a question whether weight loss plays an important role. I do believe that it is. However, having said that, most of the randomized control trials have probably demonstrated that the benefits were independent of weight loss. However, still, weight loss is a huge, big, important factor. Okay, so Prof. She talked about UKPDS a lot. I admit it was actually a small number, but it was a very interesting study because it actually involved a lot of newly diagnosed patients, and it really demonstrated a reduction in microvascular complications, and the mortality complication benefits were translated very much later on. And followed by that, we had a few positive studies like the ADVANCE and the ADT. However, he did mention about the court trial, which gave us an insight into how lowering HbA1c further could in fact be detrimental to most patients. So that was when the concept of individualization came about in terms of really looking at each patient's risk. When you actually lower it down. So we are still at the debate on whether it was the hypoglycemia or whether it was overall intensive treatment that actually contributed to the mortality. I would like to dwell a little bit about STENO2 trial because I find it a very fascinating study, beautifully designed in Denmark, which started its first publication in 2003. What it actually looked at was two groups of patients, small numbers, 160 patients, 80 per arm, that were randomized to the conventional group, standard treatment, and in the intensive group, which was actually involvement of diet and lifestyle, as well as medication, which only utilizes three things, which is metformin, sulfonylurea, particularly glycoside, and insulin, subsequently insulin, if they're not reaching target. So it's interesting for many reasons. Number one, the result, as you can see at the end of 7.8 years, it actually demonstrated reduction in cardiovascular risk here, as you can see, by 50% almost. And when the study was extended further 20 years later, and there was almost 100% still, the patients were still involved in the study, and the benefit seems to extend until then. And this, as you know, I'm sure you're familiar with the legacy effect from the UKPDS trial, or the metabolic memory, as the Americans say it, that early intensification of treatment in this group of type 2 diabetes patients will confer benefit. But what was actually interesting as well was the fact that in those with the intensive arms, obviously a small number remained, that was approximately 30 patients, but what actually they demonstrated in them was the benefit in terms of microvascular complications, renal outcome, retinopathy, and a neuropathy was actually quite significantly lower in those who received intensive arms. So therefore, in those who actually achieve good control, there is that residual risk that somehow we could actually manage further. And I'm sure you have been alarmed by Ruslinda's figure, that CKD is DKD and end-stage renal disease secondary to diabetes kidney disease is extremely prevalent in Malaysia and within our region. So is there really a role in the individual classes of anti-diabetic medications that could confer this extra cardiovascular, renal, metabolic outcomes? So just to summarize it for you, that in metformin, the UKPDS 34 study, they provided some evidence for the cardiovascular benefit for metformin, and this is particularly among the obese patients. However, there is probably limited data on large and longer term placebo-controlled cardiovascular outcome for metformin, because it's so widely used. Probably we'll look at other agents. So for the sulfonylurea is a little bit, the cardiologists have a lot of reservations about sulfonylurea because of the hypoglycemia, inconsistent results in terms of cardiovascular death or all-cause mortality. Some meta-analysis shows no consistent association in it. With the use of pioglitazone, the incidence seems to be similar. And in more recent years, Carolina study, which showed that the new CVOT following FDA guidance supported cardiovascular safety of glimepiride. So therefore, in conclusion, meta-analysis, cardiovascular safety of most sulfonylureas have not established long-term cardiovascular outcome trials. However, there is probably heterogeneity in the SU class, so it really depends on which sulfonylurea you're using. So there is recent evidence to show that the modified release or the longer acting in sulfonylureas are probably safer than the short acting ones. TZDs, I wouldn't talk too much about TZDs, only the fact that, as you know, rosiglitazone was associated with an increased cardiovascular risk and heart failure. so much so that the European as well as the American authority bodies withdrew the use, and that was removed from the use of among the anti-diabetic class. Okay, so therefore, as a healthcare provider like yourself, who is in the probably the most front, okay, so in terms of diabetic management, so when you're considering a medication, there is a need for glucose lowering medication which has proven cardiovascular and kidney safety. So which one would it be? I'm sure you've been quite highlighted to the fact that you probably boil down to two. However, you would, upon choosing, bear in mind that you also need to think of other factors. Maybe you want to think about the need for up titration, especially if the patient is coming from EPO and you cannot see the patient in the next 3 months or 6 months, or even some of our colleagues are treating patients from Indonesia. You want to consider choosing a medication you do not need to up titrate. But more importantly, I think you would need to consider the contraindications and need for dose adjustment. So for example, a patient, you've got contraindications for SGLT2s, for example, and GLP-1 if they have certain GI symptoms. So all those things that I will probably allude a little bit in detail a little bit later. But also what you need to look at are the evidences in terms of the benefits, the kidney benefits and the cardiovascular benefits, and that is what probably the focus of this talk will be. So I'm sure you've seen this over and over again, and this is again to illustrate that. Firstly, the need of cardiovascular outcome trial, okay, following a court. So what we want to look at is whether the anti-diabetic medications we're using are actually safe to our patients. But also to illustrate that it is no longer the knowledge of class effect. We believe that the compounds each have a different strength and limitation. So therefore, each medication, each compound should be tested on its own. So as you can see, the ones in purple are the DPP-4 inhibitors, the one in orange are the GLP-1 receptor agonists, and the ones in blue are the SGLT2 inhibitors. And as you can see, there are already many, but we are also looking forward to a few more in the coming few years. We are very much involved with SOL, which is the oral semaglutide, and we look forward to presenting that results in 2024. Right, but however, what has been shown previously to you over and over again, probably is the empiric outcome trial. I remember when it came out, it was a huge, big explosion in terms of empagliflozin and SGLT2 inhibitors, this thing that comes out from an apple tree. So EMPA-REG showed very significant reduction in cardiovascular outcome in patients with type 2 diabetes. And also subsequently, a few years later, LEADER came out, and that is with the use of liraglutide in GLP-1 as a GLP-1 agonist. And PIONEER, as I had mentioned, oral semaglutide, PIONEER 6 also similarly demonstrated that there is significant risk reduction in cardiovascular outcome trial, which includes death from cardiovascular death, that is with the use of empagliflozin. Oops, sorry. Right, so Linda has shown this to you just to summarize in terms of how if we put them together, the SGLT2, if you compare the two classes, SGLT2 in terms of renal outcome, SGLT2 probably has a little bit profound and significant results in terms of heart kidney outcome, including end-stage renal disease, initiation of hemodialysis, doubling of serum creatinine, but GLP-1 probably not so evident in that outcome. And the eGFR decline, similarly, SGLT2 inhibitors probably more evidence to prove that compared to GLP-1 receptor agonists. So again, in summary, when you put them together, Linda says we have to come together, the cardiovascular and kidney outcomes to put it together. Probably metformin not so significant, DPP-4 even caution with the use of saxagliptin because it increases heart failure. SGLT2 inhibitors seems to be a bit more pronounced with the use of empagliflozin significantly reducing cardiovascular death, and GLP-1 receptor agonist with liraglutide. But only reducing albuminuria with the GLP-1 receptor agonist. So therefore, I empathize with you. You're at this juncture when you are dealing with a patient, you've got all these medications, and so therefore, back in 2003 in Denmark, when when they only had metformin and gliclazide and insulin. But now you have a lot more to choose from. So which one would you choose? Because at the 21st century, patients probably know as much as you, if not more, and they'll be asking you about this medication and that medication. So where do you go from here? Okay, so guidelines are there to help you, therefore. Okay, so and guidelines are built based on most current data. So as the new studies emerge, and the guidelines adapt and evolve with it. So this is a summary in terms of a timeline on the evolution of some of the prominent guidelines within the diabetic world. In 2015, ADA and the American Diabetes Association and the European Association for Diabetes actually did include already the use of SGLT2 inhibitors and GLP-1 receptor agonists, but merely as a glucose-lowering agent. In 2016, when following EMPA-REG outcome trial, the Canadian Diabetes Association and the European Society of Cardiology included empagliflozin and particularly recommended empagliflozin to reduce cardiovascular risk and all-cause mortality. 2 years later, in 2018, the American Diabetes Association was a bit delayed in terms of mentioning that, but they did include that in that guideline in that year, that EMPA and canagliflozin were found to be recommended agents with proven benefit on MACE and cardiovascular death. However, liraglutide has only atherosclerotic cardiovascular disease benefit. In 2019, and that is 2019, following the Credence study. I remember when Credence came out, the nephrologists were very, very excited. I think they were the most excited between us three. And the EDTA and the ERA, as well as the European guidelines also evolved, and they also included the use of SGLT2 inhibitors with evidence for cardio and nephroprotection to reduce the progression of DKD. And as well as that, they included the GLP-1 receptor agonists if SGLT2 inhibitors were not tolerated. By 2020, the ADA recommended the use of GLP-1 receptor agonists or SGLT2 inhibitors with proven cardiovascular disease benefit if there is atherosclerosis, cardiovascular disease predominates, and also the use of SGLT2 inhibitors with evidence of reducing heart failure if heart failure or CKD predominates. So I'm just going to summarize that by the fact that over time, the focus of type 2 diabetes, I have to agree with Prof. Chee to some extent that HbA1c is no longer the only thing that we look at. So we have moved to the fact that HbA1c lowering is important, yes, but you also have to look at other factors to determine your choice of treatment, which includes hypoglycemia, BP, and those with weight loss. However, now we cannot ignore the fact that some medications have indeed cardiovascular benefit and renal outcome that probably might confer added benefits to your group of very, very high risk patients. So this has been the evolution over time, more than 60 years. So just looking quickly at some of the international guidelines that we have, and I'm going to go into detail a little bit. So this is the European Society of Cardiology in 2019. The guidelines specifically addresses classes of cardiovascular risk levels in patients with diabetes and pre-diabetes. So very high risk patients, that is those with diabetes and established cardiovascular disease or other target organ damage, 3 major risk factors, or early onset of type 1 diabetes and long duration of more than 20 years, and high risk and moderate risk. So the recommendation states that the glucose lowering treatment, for the first time we have evidence from several cardiovascular outcome trials that indicate cardiovascular benefits from the use of SGLT2 inhibitors and GLP-1 receptor agonists in patients with cardiovascular disease or at very high or high cardiovascular risk. So to acknowledge that. And so, however, they took one step ahead. The bit OTT I thought over the top when they removed metformin from that list altogether, and they actually recommended SGLT2 and GLP-1 as the first line therapy. So we differ in opinion on this. So the endocrinologists still think that metformin plays a major role. So with the use of so they recommended that metformin is no longer the only first-line therapy, and you should consider SGLT2 inhibitors or GLP-1 as first line in those who have not been started on metformin and very high risk or high cardiovascular risk. Okay, and all those with existing cardiovascular coronary heart disease. However, those on metformin, they were kind enough to say, okay, thank you, carry on, but you can add the SGLT2 inhibitors or GLP-1 receptor agonists on top of it. Okay. So a choice of drug to reduce cardiovascular events in patients with type 2 diabetes, they emphasize that it should be prioritized based on the presence of cardiovascular disease or severe risk, because it has already been proven that the use of these two classes of SGLT2 inhibitors and GLP-1 receptor agonists therefore should be recommended whether the patient is on metformin or not. Further on to that, they actually included a section on the use of the SGLT2 inhibitors and GLP-1 receptor agonists to recommend to reduce cardiovascular events, particularly mentioning empagliflozin to reduce risk of death, because empagliflozin is the only medication SGLT2 inhibitor. It has not been duplicated to reduce the risk of death. So, and that is class 1 and level A, for level B for empagliflozin. Right. But of course, you only want to look at ADA, right? Because that's the most important guideline in the world. So ADA guidelines have evolved to recommend SGLT2 inhibitors and GLP-1 receptor agonists. So in 2020, I'm sure you remember that. However, I just want to highlight the 2021 standards of medical care, whereby now for patients with, I also acknowledge, and Prof Chee mentioned this also in his talk previously, that for patients with established atherosclerotic cardiovascular disease or indicators of high risk, heart failure or CKD, and SGLT2 inhibitor or GLP-1 receptor agonist should be considered, yes, independent of A1C, independent of metformin use, and in consideration of patient-specific factors. However, I would like to elaborate further. Okay, so indicators, high risk, okay, agree. So all three classes. So just like to compare it with 2020. So in 2020, you had ASCVD predominates. So in 2021, in 2020 is preferably GLP-1 first, followed by SGLT2. But in 2021, it's either or. Okay, so either the use of GLP-1 or SGLT2, whichever that you feel is more suitable for the patient. And because these two medications has shown proven cardiovascular disease benefit, and therefore it should be able to reduce cardiovascular disease events significantly. But what is also different from the 2021 is the splitting of the heart failure or the CKD characteristics. When in 2021, those patients with particularly with heart failure, particularly reduced ejection fraction of EF of less than 45%, SGLT2 with proven benefit in this population should be used, and that will only include EMPA, DAPA, and canagliflozin, which has evidence in heart failure. So however, DAPA and EMPA have also primary heart failure outcome data. So they are probably stronger, if you say, in terms of evidence. So this CKD has gotten their own track. So preferably SGLT2 inhibitors is used, and preferably is, and that is based on credence. And that is with also SGLT2, because credence has the primary renal outcome, as the primary outcome, so renal outcome as the primary outcome of the trial. So that I suppose that puts it ahead of the other trials, including EMPA-REG, DECLARE-TIMI, and CANVAS. So based on the evidence from credence trial and secondary analysis of the SGLT2 inhibitor CVOTs, cardiovascular and renal events are reduced with SGLT2 inhibitor use in patients with eGFR of less than 30. So, but I would like to remind you that eGFR, now there is a discrepancy in terms of the eGFR cutoff for the medications within the SGLT2 inhibitor class. Okay, so you have to follow, I would actually advise you to follow the product insert for now until it is revised further. Okay, so the FDA Standards of Medical Care 2021 has a section whereby the explanation of SGLT2 inhibitors in terms of cardiovascular effects and renal effects, as I mentioned earlier. However, just some some additional points on the right-hand side. Should be discontinued before any scheduled surgery. DKA risk is still there, so you still have to consider it in patients who are unwell. Risk of bone fractures with canagliflozin. Genitourinary tract infections are actually not that common, but it is not rare. But what is actually quite worrying is the risk of volume depletion and hypotension. So just be careful that you actually tell patients about this, that they drink adequately if they have significant amount of diuresis. Linda had explained a little bit about KDIGO. So I was very impressed with the nephrologist for actually adopting this. So again, I suppose the recommendation really is that metformin can be the first line therapy, but also SGLT2 inhibitors, as they are currently moving towards that because of all the renal outcome benefits. So glycemic management for patients with type 2 diabetes and CKD should first and foremost lifestyle therapy. Thank you very much, nephrologist, best. First line treatment with metformin and an SGLT2 inhibitors and additional drug therapy as needed for glycemic control. So looking at this, Linda actually explained this just now. So meeting individual glycemic target, if no, then the addition of SGLT2 inhibitors should be considered. I would just like to rephrase that. SGLT2 inhibitors should be considered in patients who have no contraindication for an SGLT2 inhibitor. And if you decide to give this to their patient, a lot of discussion should be a lot of points should be discussed with the patient in terms of the potential side effects for them. However, if your patient has already met the individualized glycemic target, and what it meant is that it can lower glycemic target safely, and this is probably what I was ADA is probably trying to say, that if you already achieve HbA1c target, however, if you can add on an SGLT2 inhibitor for the cardiovascular or the renal outcome, then do so. So if you need to, you may need to lower the other antidiabetic medications that the patient is on, including insulin or sulfonylurea, and to allow you to start the SGLT2 inhibitors. Okay, so however, okay. Right, what about the national guideline? Probably this will give you a little bit of a bit more detail, some light on the HbA1c issue. So this is the National Heart Association Malaysia Primary and Secondary Prevention of Cardiovascular Disease in 2017, which also included those with diabetes without target organ and those diabetes with proteinuria. So the recommendation is the use of either metformin in low risk. But moving on to high risk and history of severe hypoglycemia and obesity, they actually recommended the use of SGLT2 inhibitors followed by the GLP-1 receptor agonists. Okay, so everyone is in line with the international guidelines as well. So in 2019, CPG on the management of heart failure also included the use of SGLT2 inhibitors, particularly those who have data to show the reduction of the risk of heart failure, as I had mentioned previously, with the heart failure studies, those with heart failure as their outcome trials. Okay, so very quickly about the Malaysian CPG, I thought it was I was not allowed to give too much details about it, but I'm sure I'm allowed to give a bit of snippets. So in terms of HbA1c, there is categorization for the levels of HbA1c. I hope that you will find this useful. So if you have those with HbA1c of these certain ranges, these are the medications that you might want to consider. If you notice the SU is quite up there, but still, I would suggest that you really look at the other risk factors that your patients may have. So, so if they're obese, you might want to start those with associated with weight reduction. So, and it's not, however, no matter how much is the HbA1c, just start HGLT2 anyway. So it's not as simple as that. If the HbA1c is very, very high the first time you see the patient, you probably need to address all the other issues in terms of weight loss or other osmotic symptoms, and whether there is a need to initiate insulin first before you actually initiate the other oral medications. What I do want to emphasize is this, that this is to remind you about the 2015 Malaysian CPG. And as you can see, there are 5 classes of patient characteristics here. In 2021, there is a little bit more. Overweight and obese has been put into one category, and normal weight followed by normal weight, increased hypoglycemia, and DKD. However, there is an addition of 3 classes, which includes the high-risk CVD, those with known disease of atherosclerotic cardiovascular disease, and those with heart failure. And these are the recommendations. So the blue line, the ones in the blue boxes are the recommended addition therapy after metformin. So metformin sits right up here. And so therefore, if they have high risk, GLP-1 receptor agonist should be started. If they have underlying atherosclerotic disease, SGLT2 inhibitor or GLP-1 receptor agonist. And if they have heart failure, so obviously SGLT2 inhibitors are recommended. So this will be the update that we have for the CPG this year. So that brings me to the end of the talk. So back to Mr. MM. So obviously Mr. MM has got all these issues and his that you have to address in terms of his poor glycemic control. So still HbA1c plays a major role in terms of what you're going to do next. Obviously, you have to consider some medications that will address his weight. Obviously, also that you need to talk to him about his diet and lifestyle, yes, but those are difficult to reinforce. So therefore, considering a medication that will result in significant weight loss could help him as well. And of course, the cardiovascular risk, his history of AMI and his CKD, which medication will have most renal impact for him. But don't forget, a lot of our patients, especially from the public hospitals, they are concerned about cost. So, but what does that mean? So cost should not hinder your choice of medications. Okay, so if you have a patient that needs it, you have to discuss with the patient on, I'm just going to go back there, and you probably have to discuss with him about the need for him to start this slightly costly medication, but in the long run may benefit him more. Okay, so in summary, just let me summarize with these few points that diabetes is a complex and it's an evolving disease. Guidelines are based on new emerging data on diabetes and its related complications. So therefore, that's why guidelines tend to change. But in general, guidelines are recommendations, they are suggestions, and it should help you to treat, to manage your patients. However, there are certain circumstances when it is too complex, and probably you have to really discuss and have an agreement with the patient, because it doesn't matter what you give if the patient is not it's not acceptable, to not accepting that medication, your treatment may not help either. But more importantly, individualization is the key word in terms of patient management. It should be based on glycemic target, again, glycemic target, and that will help you to, go which way. But also the side effects. I've got patients who has history of UTI, so you do really want to reconsider whether SGLT2 can be started with for them. Of course, other associated benefits in terms of the cardiovascular and renal benefit. If a patient tells you that I've got an underlying heart disease and you do not start them on the SGLT2 inhibitor, or at least tell them about SGLT2 inhibitor and GLP-1 receptor agonist, that would be actually non-defensible in court if anything would happen to him. In terms of cost, however, is also important, and a lot of patients. So if you feel that in your practice that the medication will confer extra benefit, you will try to get that for the patient. If not, then you really need to discuss whether the patient can find some financial support to actually get this medication for their long-term benefit. Okay, so I think that brings me to the end of my talk, Prof. Anis.
Thank you very much, Prof. Rohana. So that was very, very interesting. Lots of updates there on the CPGs, as well as snippet on the new CPG that is going to be launched today. We have now come to the panel discussion, question and answer session. So I welcome all the 3 esteemed speakers to join us for this so that we can start addressing the questions. So question number 1 there for Prof. Chee. Yeah, we have Prof. Chee online.
What we've seen on Bitcoin.
Maybe Rohana want to take this also.
Yeah. Okay. So the question goes, the HbA1c target does not exactly impact MACE is interesting. Can you venture to explain why this is so? What is the difference between ACCORD and EMPA-REG? And we have been targeting blood sugar, be it FPS or HbA1c for years, but it appears that we could be wrong. So that's the question for you, Prof.
I think the second sentences is definitely wrong. I think FPS and HbA1c, I think you still need to target it, all right? Just like what the guideline have laid out, you actually need to identify those patients who are high risk, which is cardiovascular disease, established cardiovascular disease or high risk, chronic kidney disease, and heart failure. These are the patients that you need to identify and put on the SGLT2 and GLP-1 early, because the study actually have shown that they benefited early. As in, what is the difference between EMPA-REG and ACCORD? Of course, EMPA-REG is definitely have recruited almost all patients with established cardiovascular disease. ACCORD, if I remember correctly, is about 40 to 60% patients are actually having established cardiovascular disease. That's one difference. I can't really explain why you actually see MACE benefit in EMPA and you do not see in ACCORD, where they actually focus on achieving a very good near normal HbA1c in ACCORD. My best explanation at this moment in time could be just because of the SGLT2 inhibitor itself. It could be just because of the GLP-1 receptor agonist itself. We don't really know the mechanism of SGLT2, how it works to reduce cardiac death, how it slows down the progression of heart failure. We may know a bit more about slowing down of chronic kidney disease, but until and unless the mechanism of how it works is being found out, I think the clinical trial is very, very clear, and I think the benefit is very, very clear. Maybe Rohana want to say something.
Thank you, Chee. Yes, I would like to say something, Chee. You'll be responsible for this statement. All right, so can I just mention that HbA1c, the results of the difference in the results in EMPA-REG in all the trials, which is always independent of HbA1c reduction. That is a true sentence, only because we are in a research setting. As a matter of fact, we were involved in EMPA-REG trial. We had about 20 patients from it. And when you're in a research setting, you always look after your research patients very, very well. And at that point, you don't know whether they're in the treatment arm or in the placebo arm. You can guess, but you don't know. And you are allowed to actually, by right, it's not ethical if you don't, you have to treat them to reach target anyway. So that's the very reason why any research will tell you there's not much difference in terms of the two arms, because the HbA1c target has to be optimized as much as possible with other medications. You're just not allowed to use the competitor arm medication, right? So that's the reason why there's not much difference in HbA1c. Okay, so I think HbA1c still should be looked at this, and undeniably it's probably SGLT2 inhibitors that has the extra benefit in terms of cardiovascular outcome reduction compared to ACCORD. And of course, as you know, ACCORD uses TZD, so we don't want to mention that word anymore. So so that's probably the reason why. So no, you're not wrong. Continue looking at the fasting blood sugar, continue looking at the HbA1c. Okay, all right, thank you.
Rohana, sorry, I want to follow on to that question. I saw a snippet what you showed about what's in the CPG. So for example, in the last column there, if you can highlight again, if the HbA1c of a certain figure, for example 10,
yes, above 10, above 10.
Above 10, that we go for metformin plus insulin straight away. Is that still correct?
That's what I say. Bearing in mind, the guideline is a recommendation. Okay, it's just a suggestion, because every time it's above 10%, we actually advocate for you to try to reduce the HbA1c as much as possible for two reasons. Number one, you must address the underlying osmotic symptoms that the patient may present. So especially if your patient has got weight loss, the patient is having polyuria polydipsia. So all these oral medications may not work so well, and you may end up a patient going into DKA, right? So secondly is also, I lost my train of thoughts there, but yeah, so if it's very, very high, I think we still go by the fact that you need to address the underlying pathophysiology first. And then also, yeah, because when the HbA is very high, your oral medications do not necessarily work so well if you notice. So you can start them on insulin first with diet and lifestyle, of course. And when the HbA1c kind of drops down a little bit, then you can initiate your oral medications accordingly, and you can remove the insulin slowly. So, you know, patients tend to think that once you start insulin, that's it, that's the end of the world. I'm going to get amputation, I'm going to die. But that is not necessarily so. So that is what you have to convince patients on.
Okay, thank you, Prof. Rohana. So we have question 2 now for Associate Prof. Ruslinda, I think. Oh, is it Prof. Rohana? How long will the initial dip in eGFR last when patient is started on SGLT2?
Sure. As you can see from the slide I shows, basically you can see the dip started to happen during the first 3 to 4 weeks of the study period. And of course, the median of drop is basically around 4 to 6 mils per minute. So basically when it's dropped, it's sustained in clinical trial, as Rohana pointed out, as you can see, is sustained and stable until at the end of the study. The most important that I'd like to emphasize here, when you see the dip, do not panic. All right, allow that to happen because we understand the changes in TGF, transglobal feedback, right? So this dip around 4 to 6%, of course, you monitor them. If you monitor, if you repeat the renal function at 2 weeks or 4 weeks, you see that dip, don't tempt it to stop the SGLT2 inhibitor. But what we must understand, there was a question just now, how much you allow drop in eGFR. Many nephrologists basically is what it wasn't really studied in the clinical trial, but basically most nephrologists, we follow like our RAS blockade, our ACE and ARB. If you start ACE and ARB, we stop if the eGFR drop by 20 mils. So same goes to SGLT2 inhibitor. If you decided to check on the renal function at 2 weeks or 4 weeks, then drop more than 20%. Basically, what you have to do, find out why it's happening. I basically do not blame on SGLT2. Let's say you started on this drug when the patient has A1C of 10% or 11%. You do know this patient has severe hyperosmolar symptoms. Patient might a lot of diuresis or whatnot. Then you started on SGLT2, that might not be good because later on the creatinine will jump and then we start to panic. So choose the drugs wisely. So basically when we started, let's say you started in patient with severe heart failure as well. So basically if the patient on Lasix, a lot of diuretic. So when you start the SGLT2, you try to play around along the diuretic. Try to figure out why the creatinine dropped so badly opposed to what we found in this clinical trial, around 4 to 6%. So yes, it's dropped, but after that is constant. It does not drop further. All right. So if you want to repeat the serum creatinine, I would suggest to repeat in those patients that you think at risk elderly, those on diuretic, those had poorly sugar control, and of course, just when the eGFR less than 45. So we tend to monitor them with the repeat serum creatinine at 2 or 4 weeks. Those young patients, they are independent, they're doing very well. Sometimes you don't have to repeat also, no problem.
Okay, we shall move on to the next question now. We only have 10 minutes more for Q&A. Okay, so another one here. What level of eGFR that allow us to prescribe SGLT2 inhibitor? So that's another one for Associate Prof. Ruslinda.
As I mentioned, at the moment, more than 45. So I'm waiting for the EMPA kidney. We do hope that we can start at lower eGFR from the studies basically in EMPA kidney trial that will be published in 2022, hopefully next year. We recruited patients up to 20 mils, up to stage 4 CKD. But at the moment, I believe based on the existing report and data, we prescribe in patients not less than 45.
If I can just add to that, I think Linda, I think EMPA gliflozin has recently updated to 30, I think.
Yeah, to 30, but it's yet to be approved in Malaysia. But yes, in EMPA gliflozin up to approved already. Great. All right.
I think it all depends. I think in future it all depends what kind of indication are you using SGLT2 inhibitor. So as now we only have indication for diabetes for all the SGLT2. So EMPA is not less than 30. we recently got dapagliflozin for indication for heart failure, HFrEF. Still is up to 30. Empagliflozin, that in the trial, the empagliflozin in heart failure, HFrEF, they actually recruit patient GFR on recruitment up to about 25, and they actually did not stop whatever the GFR dropped to. So it all depends on the indication. So you need to be careful of the eGFR cutoff point, depend on what is the indication. At this moment in time for diabetes, empagliflozin is 30. For heart failure, DAPA is 30.
Yeah, just echo to that, DAPA CKD trial, they do recruit up to 25, and those patients who even develop end stage actually or went into dialysis, they won't stop in the study trial. So it's just that this is a study trial. So as what I showed in KDIGO, they do suggest less than 30, try not to start the patients because it's a business study. But yes, we have to monitor them.
So the next question you have answered as well. When do we need to do the renal profile after we start this medication?
Yeah, I think I've answered this. If we started the patient on SGLT2, we repeat at 2 weeks or 4 weeks of after initiation.
2 to 4 weeks.
Yep.
Okay. All right. So next question. Okay, this is a similar question like before. Maybe we move on to the next question then. Okay. So regarding monitoring of blood sugar.
The debate question.
Okay. It's a good question. So regarding monitoring of blood sugar, I thought HbA1c was more accurate measurement than FDS. Now the latest is continuous monitoring. The more we listen to different specialists, the more confused I become as to what measurement we should follow. Your comments, please.
I think I should comment on this. Chee, what say you, Chee?
Definitely.
Okay, so can I just start? Chee will say later. Okay, all right. So HbA1c is still what we measure, but HbA1c, as Chee was trying to explain, that it can actually be influenced by other hemoglobinopathies and hemoglobin abnormalities. So for those patients who have anemia, who have polycythemia, who has thalassemia trait, and also those who have CKD, so you no longer can trust HbA1c, so you have to rely on glucose monitoring. So not particularly fasting blood sugar, but continuous glucose monitoring. So he was actually talking about the higher end of glucose monitoring with the thing, and Libra is not even available to most of us. But that would be ideal and that would be optimal. However, if you cannot, then you may need to have frequent glucose monitoring to tell you what are the levels. And what we will actually advocate, that will be in the CPG in terms of what medication you're on. So if you're on insulin, you may need to do it more frequently, and if you're on oral, maybe once a day should suffice. So in essence, you have to have monitoring, and HbA1c is still reliable because it gives you a steady state of 3 months. However, also what he was alluding to is probably the glycemic variability. So in a patient who's got HbA1c of 7, he may actually have episodes of hypo and hyper. So that one you have to go by what the patients tell you. And if they do have symptoms of hypo or even some readings of hyper, and that's when you tell them again to do a bit more frequent on the glucose monitoring. Okay, so fasting blood sugar at the onset of your clinic, for example, it may give you an indication, but I hardly look at it. I'm sure Chee hardly looks at it as well, because as he said, patients can trick you into thinking they're good control. So yeah.
Yeah, I'm actually very interested to know more about this continuous glucose monitoring, Prof. Chee. Is it like, our...
No, I'm the cardiologist. Ask the endocrinologist next.
Oh, okay. I'm not sure who mentioned this. I thought it was in your talk just now.
Yeah, he did. Now he's like, now he's denying it.
Yeah, it is a nice thing. It's just a patch. It's just a patch.
Yes.
And,
there's no
there's
needle.
actually no needle, painless. And they actually, I think they measure the sweat or secretion from the skin, and you actually can tell what's the sugar level. And Apple Watch is going to use this technology in future to actually monitor the sugar. I mean, at this moment in time, Apple Watch can actually track your pulse oximeter. So I think in future, it could be built inside the Apple Watch. I think HbA1c, don't get me wrong, is still important as a monitoring. I have no issue about it. But HbA1c as a treatment target, that I think you need to individualize and look at the patient. But I think moving forward with all the shortcoming HbA1c, we might need to move forward to continuous blood monitoring. It seems like cardiologists. I mean, 30 years ago, we actually used white cell count as a cardiac enzyme. 20 years ago, we actually used CK, and now we actually use troponin, and recently we're actually using highly sensitive troponin. I think we move on just to make the patient better, and hopefully that will actually translate into a better outcome. So what we have now is definitely good enough. It's actually HbA1c, but we look forward for something better in future. That's my thought.
So great. So in the future, so while we wear Apple Watch to monitor our heart rate, we can monitor our blood sugar as well. So I wear Fitbit for to monitor my 24-hour heart rate. So I hope this will be accurate too, not just for diabetic patients in the future. Very, very interesting indeed. Okay, I've been informed by the organizers that this will be the last question as we are running late. So I suppose we have got lots of questions actually. So for the rest of the questions, I hope the panel will be able to directly answer them through the chat box, probably direct to the participants if you have time. And probably can email to the participants as well, answers of all the questions. Because they all need to be answered, I'm sure. They're all burning questions from our colleagues in primary care. So with that, we shall now have a short break, toilet break for about 10 minutes before I pass the session over to Dr. Lim, who's going to moderate the next session. Okay, thank you very much, everyone. Thank you very much, all panels. We shall end here and have our break now. Thank you.
In September 2015, at the EASD, I had the honor of presenting the cardiovascular outcome results from the EMPA-REG outcome trial. I can remember the excitement in the Congress Hall that day in Stockholm, Sweden. You could literally hear a pin drop as I revealed the results, silence which quickly turned into applause. The key results from the EMPA-REG outcome trial was that treatment with the SGLT2 inhibitor empagliflozin reduced the risk of the primary outcome, 3-point MACE, by 14%. There was also a 38% relative risk reduction in cardiovascular death, 35% for heart failure hospitalization.
We realized that for the first time, we are witnessing a diabetes therapy that not only improves glucose control, but has a major impact on the devastating cardiovascular outcomes and renal complications of type 2 diabetes.
The magnitude of the effect was totally unexpected. It never happened before in history. I remember exactly, I said, this is too good to be true.
The mortality effect in particular was large. It was clinically important and statistically persuasive based on substantial number of events, and was seen with both doses across multiple subgroups. So it was unlikely to be a case of too good to be true. So personally, quite frankly, I was thrilled that the holy grail of diabetes had been finally achieved.
The last 5 years have certainly been a very exciting time in diabetes, and most importantly, very good news for our patients.
Well, the promise and potential of SGLT2 inhibitors that was first revealed in the EMPA-REG outcome trial has been validated in subsequent trials.
We wrote more than 50 manuscripts about all the effects. It stimulated the heart failure trials, EMPEROR and the EMPA-KIDNEY trial.
We are now entering a new era where we can expect to improve glucose control and achieve all the benefits of improving glucose control, but in addition, are able to reduce the impact of heart failure, in addition, able to reduce the impact of cardiovascular death that occurs in diabetes, and slow the progression of renal disease.
On the 17th of September 2015, the results from the EMPA-REG outcome trial were released during the EASD meeting.
Okay, shall we resume our session? Yes, okay. So welcome back from the break. We have now come to the conversation with the experts, getting them to answer your questions for half an hour. I'm going to pass over the session to our next moderator, Dr.Lim Hooi Min. So before that, let me introduce her. Dr. Lim is a family physician practicing in University of Malaya Medical Center. She completed her specialty training in Master of Family Medicine in in the year of 2018. She also lectures in the Department of Primary Care Medicine in for both undergraduate and postgraduate. Dr. Lim's research area are cardiovascular health, including cardiovascular risk stratification, diabetes, and hypertension. She has published several research papers in the ISI peer-reviewed journal, and she has received several awards such as the Asia Pacific Society of Hypertension Young Investigator Award and the Malaysian Society of Hypertension Young Investigator Award. At the international level, she is a research fellow for the International Society of Cardiovascular Disease, Epidemiology and Prevention, ISAP, and the International Society of Hypertension. So welcome, Dr. Lim, to moderate the session, and I will end my moderating here. Thank you very much.
Hi, good morning, everyone. Thank you, Prof. Anis. So my name is Hooi Min. Thanks for the great, good introduction. So thank you for all the participants who have submitted your cases. So in total, from last week, we have received 7 cases. And because of the time limit, we will try to discuss about 3 to 5 cases if time is we have enough time to discuss this. So it's a great pleasure to have all the 3 experts with us today. Let's start our first case. So the first case, this is a 40-year-old man with type 2 diabetes for 3 years. He has obese type 2 with a BMI of 37. So this is his home self-monitoring of blood sugar result. The fasting sugar was 7 to 9. And the 2-hour postprandial was 15. So this is his medication. He's on subcut mixed 80 unit BD and metformin 1 gram BD. So his diet is well controlled. The doctor also has assessed his insulin technique, which was generally good. There's no diabetes complication. I think the doctor's question is how to treat insulin resistance diabetes. So as we all know, insulin resistance, when we talk about it, is when the patients require insulin dosage of more than 1 unit per kilo per day. And when they have this insulin resistance, when we give higher insulins, then they have weight gain, and the fat cells will also lead to more insulin resistance. So probably we can ask Prof. Rohana, what is your advice on how to manage diabetic patients with insulin resistance?
Thank you very much, Lim. A very interesting case, and I'm sure that you see a lot of this. So, but firstly, let me highlight the fact that the patient is in an extremely high level of insulin dose. So firstly, that you need to establish is probably whether the patient is injecting at all. So compliance and adherence to dietary is, are we moving to case 2, Lim? Sorry, yeah, can I just have a look again? So insulin technique you said was good, but is he really taking it? Is he compliant to the medication? Is he adhering to his dietary and lifestyle restrictions? But putting that aside, if you've already established that, I would actually suggest that you revise the medication. So it depends on what oral diabetic medications you have. So I would start with DPP-4, will be useful, combination with metformin, optimize the dose of the metformin and the DPP-4 inhibitors if it's available to you. But if you have a choice, you would want to have something which can address the obesity stage 2, I presume here, the BMR 37, so with either the use of GLP-1 or the SGLT2 inhibitors. So that will indeed, you should be able to bring down your insulin doses, because as you know, the insulin will cause further weight gain.
Yeah. So, Prof, what is your thought about changing the mixed diet to basal bolus insulin?
I don't think that will be a good choice at this point in time, because that will only increase their chance of increasing their weight. So, and you're not exactly addressing the underlying pathophysiology, which is not just to give the insulin to overcome the insulin resistance, but also to use other oral diabetic medications that can increase insulin sensitivity. So you can use the DPP-4 inhibitors. Sometimes you have these patients who do very well, and also SGLT2. You can just promote glycosuria, and weight loss, and of course the GLP-1. But of course they are more expensive. So I think a combination of the other oral medications should go a long way for this patient.
Yeah. So thank you very much.
If you actually look at the fasting 7 to 9 and 2 hours 15, I presume he is actually injecting. So let's say he is injecting, and you're going to start, let's say, SGLT2 inhibitor, let's say empagliflozin 25. So how are you going to bring down the mixed up to accommodate for the
Okay, so generally we say reduction when you're initiating the SGLT2 inhibitors, because SGLT2 inhibitors do not induce hypoglycemia, but in combination with insulin and SU, they do because of the latter two compounds. So generally we say reduce your insulin by 20 to 30% when you're initiating the SGLT2 inhibitors, and then you can up titrate again. So you can start with just reduction to 60 units. And when you're initiating, and then you can up titrate, or if needs be, you may need to reduce further when the patient is experiencing hypoglycemia.
I think to the person who actually asked this question, I assume that he has no contraindications such as kidney failure for us to start all the things that we want to start.
Yeah, absolutely. Yeah. So thank you very much for the comments and your opinion. So I think all the panel has explained and answered the questions very well. So second case is a 35-year-old man with underlying diabetes. So I think the doctor previously started the patient on perindopril 2 milligram OD because he has 1+ proteinuria due to uncontrolled diabetes. But I don't have the HbA1c level for this case. The blood pressure has improved after frequent gym workout and diet control. So he's taking whey protein for bodybuilding. So last week follow-up, he was still having proteinuria 1+ with normal eGFR. So his or her question is, do I need to advise him to cut down his protein intake, increase ACE inhibitor dose, or add in SGLT2 inhibitors? So probably the most suitable person to ask is Prof. Ruslinda. So actually this is a very common case that we see in early diabetic kidney disease in primary care setting. So I think the doctor is in a dilemma whether to increase the ACE inhibitor dose or to add in the SGLT2 inhibitors. What is your comment about this?
Thank you, Lim. It's quite interesting. Rohana, 35 years old with diabetes. So
That's
I hope it's
quite common, Linda.
Yeah. Now with the metabolic syndrome, whatnot.
But Linda, can I just interrupt you for one
Sure.
second and tell Chee, you see, it's all your fault because now HbA1c they don't even bother. My God.
That's the problem. Now we are getting younger and younger type diabetes patients. So I'm sure he does have hypertension as well. We are not given about BMI, whatnot. The first thing that we have to emphasize here, this patient taking whey protein. Yeah. Sometimes when you have this proteinuria from this state, you need to understand whether it is truly glomerular proteinuria or because of supplementation that has been taking it. So normally, I would like to have a serial reading. But if this is truly because he's taking a high protein diet and he has proteinuria, I would advise the patient to stop first and reassess back. Let's say make it true that this patient truly have proteinuria because of diabetes mellitus. So I believe in terms of management early decade, definitely this patient needs to be on some sort of anti-proteinuric medication. We're not talking about albuminuria here anymore. Now we are talking about proteinuria because this patient had dipstick of protein positive plus, right? So there's a overt proteinuria. So I would, depending on the blood pressure, yeah, if the patient blood pressure is still not well controlled, of course, as I mentioned earlier, the most important holistic approach, make sure you can optimize further the RAS blockade, ACE inhibitor, you can optimize further. And if the sugar is not controlled and the blood pressure well controlled, this is where you may consider adding on SGLT2 because this patient already had an overt proteinuria. Of course, actually, I don't really know the effect of high protein diet on the SGLT2 because you must understand when people are taking high protein diet, so basically high protein diet also will alter our transglomerular feedback mechanism. That's a problem because we are talking about SGLT on that TGF, but proteinuria, high protein diet also will alter that mechanism. So when you take a lot of protein, so what happens? There will be reabsorptions of amino acids, and that we call the dilatations of afferent. So basically, this against the SGLT2 feedback theoretically, but to be honest, whether this is going to be impact, we need a further trial to see those with high protein diet, normal protein diet, and whether they are on SGLT2, whether is there any alterations or outcome different. I don't know about that. But of course, if to answer the third question, do I need to reduce my protein intake? I would suggest yes for this juncture because we want to understand whether reduction of protein intake will eventually also lead to the reductions of proteinuria. We need to quantify the urine protein. Yeah. Any comment, Prof. Rana?
I think in this case, I will actually increase the ACE inhibitor if the blood pressure is allowed, and at the same time, I will actually add in the SGLT2 inhibitor, regardless whether the sugar is well controlled or not. I think this is what is being laid out in the ADA 2021 guideline. Sugar control shouldn't be a consideration when you are having this kind of proteinuria. So I think SGLT2 or GLP-1 receptor agonist should be given. At the same time, you might want to up titrate your ACE inhibitor dose.
Yeah.
Not to say sugar not important, just that regardless whatever the HbA1c level, whatever it is, whether it's well controlled or not well controlled, SGLT2 should be added in. That's what I'm saying.
You see, Chee, you just had to ask me to comment on whatever you were saying. See?
You're more than welcome.
So anyway, I agree. Maybe there is a role in ACE inhibitor and SGLT2 inhibitors. However, bearing in mind that both agents cause an increase, or rather an increase in creatinine or reduction in EGFR, so I would be very worried to start it together. Yeah. So perhaps you can do it, subsequently, kind of. But if you are only given one choice, which I find weird, we can actually do 2 things or 3 things at the same time. But you need to ask him to reduce his protein intake, yes. But if I were to look at which of the three that you have given there, reduce protein intake, increase ACE inhibitor, or add SGLT2 inhibitor, which would address all the issues that you have put there, which is the proteinuria with the uncontrolled sugar. We noticed that, and without the HbA1c, uncontrolled sugar, and the blood pressure. So I suppose the SGLT2 inhibitor would probably address all three. So it will improve the renal outcome, reduce the sugar, and it will reduce the blood pressure. So if you have a choice, perhaps SGLT2 inhibitor would be good. But bearing in mind that you have to consider if he has any contraindications to the compound.
Yeah. Okay. Good. Great. I think for this case is really a very good case illustrating early diabetic kidney disease in primary care. So probably we can go to the third case. This is an elderly patient, 78-year-old lady with underlying diabetes, hypertension, and dyslipidemia. So her doctor stopped her metformin 4 months ago as HbA1c was very good, 5.6%. And her current medication is telmisartan 40 mg OD and simvastatin 20 mg ON. So currently she has no osmotic symptoms and she eats balanced diet. So when the patients return, the recent HbA1c is 7.3%, creatinine level 78, fasting sugar 11.3, and the doctor's question is, what is the suggested next management? So I think this is what previously Prof Chee and Prof Rohana talked about, the individualized HbA1c level. So what is your opinion about this?
Who are you asking?
Yeah, probably Prof Chee first.
No.
Do you want to go, Chee? Ladies first lah. Ladies first. Okay. All right.
Yeah,
Chivalry is not lost. But anyway, all right. So I suppose, Lim, this case illustrates diabetes in an elderly. Okay. A few things to highlight. I presume she's got no underlying complications despite being diabetic for a significant amount of time. Can't see any. So in terms of, firstly, it's glycemic control, HbA1c 7.3. What would be her level? Okay. So the guideline says you try to reach for 7% if there's no contraindication, if there's no underlying comorbidity. So in her case, let's assume that she doesn't have it because it's not mentioned. So let's try to see whether we can reduce it down to 7.3, because as you can see, fasting sugar is still 11.3. So my question to the doctor who posed this is, why did you stop the metformin? I know why, but how much was the metformin she was on? So if she was on high doses, like 1 gram, so you can just give a small dose, 500 milligram. I presume she's quite small. So maybe even a 250 can actually address the underlying fasting blood sugar. Okay. But if, and again, because the EGFR is not given, if the metformin is contraindicated for some reason, perhaps lower doses of DPP4 inhibitor should also be able to address the the fasting sugar. The reason why DPP4 inhibitors, for example, linagliptin, as I would like them to say, is probably preferable in this case is there's no dose adjustment in terms of CKD. There is a renal benefit as well. And also the reason why SGLT2 and GLP-1 are not desirable is probably in the elderly. It may cause loss of muscle bulk in terms of when they're experiencing the weight loss. So which probably we don't know so much information about that right now. So probably to err on the side of caution, the DPP4 would be probably the best option for her. That's my opinion. Over to the cardiologist.
I would not do anything because if you actually look at the individual HbA1c target for her, I should be around 7.3. I think he's already having a nice HbA1c. Why do you still want to give her medication? And he's already 78 years, so what kind of complication are you trying to prevent? Sorry, I just want to be the devil's advocate here.
Would you not be concerned about the fasting sugar of more than 10, Prof Chee?
Not really. If the HbA1c is 7.3, this is a patient that I would actually want to look at a continuous sugar monitoring. Why should he get a sugar 11.3, but the HbA1c is 7.3?
Prof Rohana, the EGFR is 73.
Oh.
So would you consider SGLT2 since you are really taking into account of fasting sugar of 11.3?
No, I still wouldn't.
Right. I would not.
If the HbA1c is higher, there you go, Chee. agreement at one.
I managed to find agreement.
Yeah.
So
See, the
perhaps,
nephrologists are always the nice one that binds us together.
Yeah.
I'm always a
this...
bit hesitant with old people giving SGLT2 and I'm always a bit hesitant unless they have very, very strong indication like established cardiovascular disease or whatever. But in this kind of cases, although if you actually look at the diabetic hypertension and dyslipidemia by itself, if you actually follow the ESC guideline, it's considered very high risk. And they should, if you actually look at the European guideline, it's actually SGLT2 or GLP-1 as the word go. But my personal opinion is I'm very, very hesitant. I'm not sure about Rohana. In this group, I wouldn't give SGLT2 as my first choice, despite the fact that actually we're high risk.
Yeah. But could I also comment that I think there's a discrepancy in terms of HbA1c and the 11.3 fasting blood sugar, because usually they go together. So so you might want to look at the fasting blood sugar at a few occasions. Maybe she had a durian cake the night before or something like that made the sugar very high. But however, I think patients tend to get worried when the sugar goes up. So being an elderly and I have all these patients that the children will say, "Oh, mom, you can't eat this and you can't eat that." And the poor lady, she's at the end of her time. So you want her to enjoy a little bit more. So, give her something at least that can help her with the sugar so she can have a little bit more luxury in life. So it's my take on it. Yeah. Thank you.
So thank you. So perhaps in this case, the point to learn from here is to kind of when you try to prescribe medicine, especially for elderly, we should go slow. Perhaps like what Prof Rohana mentioned just now is try to reduce the dose first before we totally off the medicine. Yeah. So I think we can go to the fourth case. Is a 50-year-old man, diabetes with autonomic diabetic gastroparesis, obesity. The HbA1c was 8.5%. So the medication is atrapid 24 unit TDS, insulatard 30 unit on ON. So he has recent heavy carbohydrate exchange due to relative hypoglycemia. So this is his pre-meal sugar 10. The doctor has reduced the subcut atrapid to 20 unit TDS and changed insulatard to glargine 34 unit ON. So his question is, if I plan to add on SGLT2 inhibitor for him, how do I titrate down his insulin dose? Perhaps we can ask Prof Rohana about this.
You should ask the cardiologist.
No. Yeah, anything more than 3 different types of insulin, I will never understand.
Right. Okay. Thank you very much. I think this is an extreme, the end of the extreme cases whereby there's a lot of complications. Okay. So HbA1c 8.5 in somebody who's got autonomic diabetic gastroparesis, you are probably aiming at 7.5, and depends on, you really want to avoid hypoglycemia, because once they have autonomic autonomic neuropathy, they are really prone to hypoglycemic unawareness, right? Okay, so if you answer your question, how do I titrate? You start with the SGLT2 inhibitor. You, as I mentioned earlier, you reduce the dose by 20% at least, 20 to 30%, and then you up titrate it. Generally, if the HbA1c is 8.5%, he would require, probably with the addition of SGLT2, it will reduce it to about 7%. So you probably require the same dose eventually, okay? So, but as well as that, you might want to consider using the other medications that can avoid hypoglycemia. So you introduce SGLT2 inhibitors, and if he persistently experiences hypoglycemia, you might want to discuss whether he's able to either use GLP-1 if he's obese, as you mentioned. If not, then just addition of a DPP-4 inhibitor and try to lower down the insulin further. But having said that, this patient is at the extreme end of the diabetes complication, as I mentioned. So ultimately, he would require insulin therapy. But as well as that, the analog seems to reduce insulin hypoglycemic events more. So you might want to consider the use of the co-formulations, Degludec maybe, or Ryzodex maybe, or even the use of Novomix TDS. Whether that can help you if it is accessible to you.
Yeah, true question for Rohana. I mean, would you think that this one might be a good case for continuous insulin pump? That's my first question. Second question is that this patient actually have diabetic gastroparesis. do you think do you think it's suitable for GLP-1 receptor agonist, or you would not give it to this group of patients?
Yeah, that is the point. Thank you, Chief, for highlighting that. There's oversight, but it depends really on what are his symptoms. So if his symptoms are the dumping, very severe, probably obviously GLP-1 is probably not a good option. But if it's not too severe, because we hardly see, it's actually quite uncommon for us to look at to find severe gastroparesis. You can actually try it first and see how he gets on with it. It's not really a contraindication, I'd say.
Okay, so thank you.
Yes, for the sugar monitoring, yeah, of course. Somebody who experiences hypoglycemia, I would go start with the glucometers first. I mean, if they can do very frequent glucometer pre-meal, post-meal, then that should suffice. But if if you can't get much information from the glucometer readings, glucose monitoring would be an option as well. It's just that sometimes when you have the CGM on for 3 days at least, it's kind of quite burdensome for some patients, and it can actually be quite what's the word for it? It's a very simulated event, when you have the CGM on, so you'll be a bit more well behaved in terms of your food intake. So sometimes it's not that accurate.
Yeah. So thank you very much. I think relative hypoglycemia is quite tricky to manage in primary care setting, as they experience hypoglycemia even with the sugar level of 7 or 8. So I think your suggestions of adding SGLT2 or changing to DPP4 inhibitor would be quite enlightened to us, and one of the solutions that we can use for this. So thank you very much for this. I think it comes to the last case. Is a 34-year-old man with diabetes, fasting sugar 5.6, HbA1c 6%. So his medication is quite complex. He has this dulaglutide, which is a GLP-1RA, insulin aspart, insulin degludec with aspart, empagliflozin, and metformin. So the doctor's question is, should I adjust or down titrate his medications? So could I ask the expert panel about this? I think this is quite a rare case in primary case where we don't really start GLP-1, but it's a good case to discuss.
I take it I should start? Oh.
Yeah, sure, Prof Rohana.
I insist, cardiologist.
Every question is a debate question.
Okay. So, firstly, I would like to clarify whether he's type 1 or type 2 diabetes, but I presume because he's quite young. And he's obese, and I presume so. Okay, so because he's on 2 medications, GLP-1 and EMPA, and I presume he's an executive somewhere earning lots and lots of money. But anyway, so if your question, should I adjust or down titrate? Yes. The next question is which one? I would say you go for the insulin that you want to try to reduce further, okay, if possible. If the patient is obese, that is, again, that is the main point here. That you want to try to reduce the weight as much as possible. So you want to remove the aspart, can do with once daily degludec first, and continue on the dula and the EMPA. Your target is still 6.5%. And once you can achieve that without the aspart, then you can continue on with there's no contraindication. If the HbA1c drops further, you might want to consider to down titrate the insulin, degludec, as a Rhizodec further. So that would be my opinion on it. But the EMPA and the empagliflozin will probably be the last medication you want to remove.
So is there any precautions that we should look at when we mix the GLP-1RA with basal bolus insulin?
No, just compliance, Lim, I say. Because after lots and lots of injections, sometimes the patients can get really bored.
Yeah, definitely. Yeah.
And HbA1c of 6, I expect him to have a bit more hypoglycemic episode.
Yeah.
Yeah. So so thank you very much. I think this is our last case. So thank you very much for all the experts for the great discussion. I think the
Lim, I think we had two more questions. Any role to repeat RP after starting Jardiance like its inhibitor? Oh yeah, we've answered that. Chee, would you like to answer that question on alcohol? Have we stopped?
Yeah, I think I have a quick search. There's actually no real contraindication. Just that if you actually take alcohol, there's a risk of low blood sugar because you might be drunk and not eating. So I think that if the patient is on Jardiance plus a lot of insulin, I think this is, you need to be careful. Not the Jardiance and the alcohol itself, but it could be because of not eating and all that. So that's based on what I have managed to search.
Okay, I think we have, I checked through the Q&A section. So yeah, role of repeating RP, I think we have answered this before, and all the questions also have been answered by the expert in the chat box. So thank you very much for all the experts and also all the participants to stay with us. I think we would close the session, but before this, please remember to register yourself with the MMA to get your CPD point. Can I have the CPD point slide for everyone? Yeah, so 4 CPD points will be given for this webinar, and please download your MMA application. So we have this CPD point QR code will be shared at the end of the session. So, and as an alternative, attendance list will be submitted manually to the MMA post-event CPD points accreditation. So here is the QR code for the MMA points. So thank you very much, everyone, for attending this webinar and this primary care workshop. I hope everyone will have a great weekend.